Everyone has a role to play in PHM. We don't really want it as a standalone project. We want it to be something that is embedded in core business as usual activities.
Population health management enables us to really work with our communities impacted by health inequalities to make sure that we come up with joint solutions and interventions that can really make a difference to their health outcomes and close that gap we see.
It's really, really important to bring together data on as many aspects of things that make people healthy and give them well-being as we possibly can. That includes data on health, it includes data on social care for adults and children. It also includes much wider data sets, for example, education, housing, welfare. The work with Optum through the population health management work, Pathfinder, has been really key to that.
Population health management really began in Suffolk with a national programme. We were part of a pilot and we worked with Optum as part of that pilot to create a linked data set. I joined Suffolk County Council from a non-health background, and for somebody like me, I just assumed that all data was linked together, and it came as a bit of a shock to find out that actually all the data kind of sat in silos across the systems. GP data in primary care was really very separate to hospital data, and sometimes clinicians couldn't really see what was going on in different settings for the same patient. You can't really do integrated care well if you haven't got integrated data. Population health management, kind of bringing all that data together, has just really revolutionised the way that we do things.
The key starting point was when the ICB was formed. We embedded population health management into our joint forward plan. And then from there, we established our linked data sets across primary, secondary and adult social care. We were then able to work with Optum to establish our strategic population health management reporting platform, which was really about democratising insights in population health to frontline healthcare professionals.
Everybody was working for the same agenda, trying to really improve population health, reduce inequalities, but we hadn't brought them together as part of the data conversation with the intervention conversation, but also making sure that community voice is heard within that.
At the outset, we were nationally advised that we had to spend a proportion of our budget on prevention. It's really hard to move that resource. So it was about how we could use the data to support that debate around moving resources from one care setting to another.
We want to be evidence-informed and intelligence-led in all of the work that we're doing across the ICS, from commissioning through to delivery of direct care. Making sure that we are thinking about the best patient experience that we can give, particularly through kind of more proactive interventions, thinking about how we take a patient-centred approach to delivery of healthcare. It's also about how we can operate as efficiently as we possibly can.
We've known for years that inequalities are bad for health. We know that some people can't access services and that's bad for health. Working with Optum has enabled us to say, actually, where it's appropriate and lawful to do so, who is that? Which groups are those in our local population, not just theory in a textbook? I have a real saying, I drive my teams mad. I say we don't just do data, we do data for action. The opportunities for public health and health commissioning through PHM are absolutely endless, and we are only starting to scratch the surface.
The Suffolk and North East Essex Integrated Care System Population Health Management Strategy talks to 5 key objectives: improving productivity, improving the population's experience of health and care services, the overall population health and well-being, improving health inequalities and access to services, and then finally improving workforce morale and engagement. We currently have 45 projects that are being worked on that apply population health management techniques, and that might be a variety in different ways in which we apply those techniques. We may use population health management to identify where we should place a service or solution, a clinic or health station, for example. Opportunities for us to make improvements in access or outcomes. It may be that we start with a particular intervention or solution that we want to embed, look at that and say who would be best impacted or who would that be most effective for across our population.
The overall infrastructure, we've basically got 3 key pillars to that: the people, the tools and the data. We've got all of our national commissioning data sets, all of our data from primary care. At the moment, we've got all but one GP practice who shares their data with us for PHM use. What we're able to do is use a pseudonymised NHS number as a common key that runs through all of those data sets, and we can link them all together. So that gives us a full picture of a patient's entire journey from going to the GP all the way through to ending up in hospital. And that gives us a really rich understanding of the kind of prevalence of conditions in our population, but also their use of healthcare services as well.
It helps us identify people who've got long-term conditions who aren't particularly well controlled or reaching their targets. One good example is blood pressure. Another big area is looking at emergency admissions. Traditionally, we've always looked at the data, found people who are quite high-end users and tried to manage them, but actually the data helps us identify people who are at risk of becoming those people in the future.
We've developed in SNIA an intelligence function, and that's a group of colleagues that work in all of the different areas of the SNIA ICS, so county council, ICB people, local providers. They've all got access to that same linked data set, so we can work really collaboratively and come up with some really excellent bits of work.
The team have done some really excellent work on who does or doesn't attend for cancer screening services and actually how likely those people are to be developing cancer, and that is completely game-changing.
We use Pathfinder, which we procured from Optum, as our kind of open source tool, so that's our kind of reporting solution. We've got about 300 users across the ICS from various different roles.
A lot of frontline practitioners, clinicians, some of them are very competent with data and tools, some of them absolutely would rather do anything else. So coming up with a front end, if you like, to the data set that you can't break, you can't see anything you shouldn't be able to see, and crucially, you can use for yourself fairly quickly. We've effectively created an army of people on the ground who are doing that thinking, doing that work, and using the tools safely and appropriately to do it.
So I think the key challenges that we've experienced within Suffolk and North East Essex in implementing population health management at scale is actually building the workforce's confidence to use the linked data set to ensure that population health management is everybody's business rather than an add-on to anybody's kind of particular role. The way that we've overcome that particular challenge and built that capacity and capability is by delivering training on a monthly basis across the integrated care system.
It's not about siloed pathways anymore, and it's really important that we are looking at things in a much more holistic way. It's how we use it at scale. It's how we get that transformative change across populations. We've created 11 recommendations, and working together we'll have a delivery plan and challenge statements, using those statements to work with commercial partners. We know what and where we need to do things. It's working with others to do the how.
Where you live can determine how long you live, and that should not be the case. Making health outcomes equitable across the population is our ultimate aim, but with PHM we've got that.
Once we've built the case for change, you can then rally your troops, and the data is a compelling and convincing argument to do that.
Now the infrastructure in the organisation feels right and is moving in the right direction. We can now really genuinely start to work together to drive this forward at a pace we haven't been able to do so before.
Don't overcomplicate it. There's significant progress that can be made using the tools that we've already got.
The more people you can involve in doing this, the more quickly you can then get to the issues that really matter, the issues that really could make a difference.
We can trust in the data that's being given to us, and then we can use that to really make a difference to our population.
Finally, for us, we can just bring it all together and we will make a shift in health outcomes for the better for our communities.
You really need good clinical engagement and leadership to win the hearts and minds of particularly healthcare practitioners to translate this into something that's fundamentally about improving care quality and improving the experience of patients.
There are no strong reasons not to do this now. There are ways of doing it lawfully, safely and appropriately, and there are enormous potential benefits to the populations that we serve.